Welcome to Frontline Nursing, a NurseMinder production that gives you an insider's look into the daily life of nursing from those who are currently working on the front lines. Whether you're considering nursing as a profession, you're a student already, or you're a nurse in transition looking for a new patient population, this show will give you some behind-the-scenes information to help you guide your career. So get those note apps and pens and papers ready because today is going to be a good one. Today on Frontline Nursing, we are joined with Kelsey Penner. She is a critical care nurse working in the ICU, eMERGE, and inpatient transport. Welcome to the show, Kelsey.
Hi, thanks so much for having me.
I am super excited to have you. It's been a long time since we have seen each other.
Yeah, it's been years.
Yeah, so for those who are listening, Kelsey and I first met in the military during our nursing careers where we worked a little bit together. And so we're going to start out just by diving in and finding out what brought you to nursing, and then we'll talk a little bit more about your specialties.
Sure, that sounds great. So to start out, I was always somebody who I think actually at one point in high school, I was quoted to say, "I will never be a nurse." That sounds like an awful career. All you do is pass out pills and follow doctor's orders, and that just doesn't sound like something that I really want to do. I'm totally eating my words now, 20 years later in this career. So I actually started out, my first degree is a kinesiology degree in athletic therapy. And I went to the University of Manitoba, did a 4-year degree there. And when I was in my last year, I really was starting to look at the job opportunities. There were not a lot in Winnipeg where I live. Might have to move. I was doing a lot of traveling with semi-professional university level sports teams. And I was finding that it just really wasn't something that I was super enjoying. And at the same time, I also happened to be in the Army Reserve. I joined a few years previous and was really enjoying that. And when I was in my 4th year, it was very early in the year. Afghanistan had just kind of gotten started. I think this was around 2005. And I actually had a dream one night that I was a nurse, that I was a critical care nurse, that I was deployed overseas and working as like part of a trauma team, a high energy environment. And I literally woke up the next morning and I was like, that's what I want to be when I grow up. And I know that sounds so corny. So by the end, that same day, I was online, was checking out my options. May not have been fully online. There might have been some phone calls at that point. I think it was more the technology at that time. But within a couple of days, I had gone to see an advisor in the program at U of M to kind of get some information about what credits I had, what credits I might need, how I could mold my final term of university. And she was incredibly helpful. She actually, by taking a couple of evening classes, I was able to mold my whole term so that I could start in the 2nd year of the 4th year nursing program.
Wow.
So that I was so grateful for her advice on that. And I also decided I was sick of canned soup and craft dinner. So being a starving student, I had done it for 1 degree already. And I thought, you know what, I love the military. This is what I want to do. Trauma nursing is what I want to do. So I enrolled in the ROTP program and let them provide some salary for me while I went to school, plus pay for my education and books. And that was definitely a decision that I have never, ever regretted.
That's fascinating. I had no idea that you had a kinesiology degree. Did you get credit for the kinesiology degree?
Like from the military? Not particularly.
No, just from the University of Manitoba, because you'd started 3
Oh
years.
yes, sorry. I did graduate with that degree in 2008. Yeah, I definitely finished it. I mean, I had done pretty well all of the degree requirements, and I was finishing things out. So definitely finished that degree. It's come in handy, certainly in my early days as a nurse, working more like in the clinic and stuff, as the clinic on the military base. I remember one day I worked with the physiotherapist on the base just to kind of get a couple days of physio famil. And after working with him, he, for about 30 minutes, he was like, "You could just work here with me." You're quite up to snuff on your orthopedic assessment and your treatment modalities and things like that. Because nurses don't often get a lot of that unless they go into primary care. Like I think if you go into a primary care program, you would get a little bit more of that stuff. But when you're in your undergraduate program, you get your anatomy. You just kind of breeze by it, and okay, it's an ankle sprain. I don't know what ligament it is. I know it's an ankle sprain.
Yeah, exactly.
So it was a good opportunity for me for sure.
Was that just out of curiosity? Was that with Donovan?
It was, yeah.
Yeah, shout out to Donovan.
Yeah, yeah. He still works there. I still, yeah, prior to the gym closing as it currently is right now, I still see him there all the time.
Oh, that's great. We'll have to let him know that he's been mentioned now in the podcast and get him to take a listen.
For sure.
That's awesome. You know, you mentioned that additional assessment piece and kinesiology. That's you actually got to work on cadavers, as I understand it, in that degree. Is that right?
Yes, I actually I got more anatomy and physiology from
Mhm.
my kinesiology degree than I did my nursing degree. I actually got 9 credit hours of anatomy and 6 of physiology. And the University of Manitoba nursing program, you only get 3 credit hours of each. So I got way more A and P than my nursing colleagues did. So I was actually really grateful for that. It came in handy for sure, especially the physiology, particularly getting into the med surge and even throughout my ICU training and things like that too.
We talked a little bit offline before we got started here about emerge nursing and the new trend, and it has actually, it's not really new. It's been going on for quite a while that you can graduate and go straight into emerge. And you know what we kind of thought about that. Certainly when I went into emerge, you had to have 2 years of floor experience before you went in. And for myself, I found that really helpful. What was your perspective? Did you get to go straight into emerge, or were you on the floors as well?
No, I started on the floors as well. I know that 2-year rule. I think they had just kind of started abandoning that right around the time that I was graduating or that I was selecting my senior practicum. And I did ask a couple of very experienced nurses in critical care, and I said, "This is what I want to be when I grow up. Like I'm 100% certain I want to be in emerge, want to be in the ICU. Um, how do I get there? Should I go to emerge for my practicum?" And they had all said, no, where you want to go is a super high acuity ward where you get the patients from emerge, where you can learn your organizational skills, you can learn how to time manage, you can learn about all of those different things, chest tubes and dressings and, you know, um, polypharmacy and kind of all of these different things that happen on a ward, learn about different consult services and how residents fit into the picture, how med students fit into the picture at a major teaching hospital. So I went to a trauma acute care surgery ward in the same hospital, where they also have a 4-bed ICU step down. So our normal ratio is 6-1, and then the step down is 2-1. So patients coming directly out of the surgical ICU, where I know you've worked as well.
Mhm.
So pretty sick, and it was definitely a great opportunity. I was so fortunate. I was blessed with a preceptor that had over 30 years bedside nursing experience, and her and I are tight. We still send one other Christmas card every year. Like she's amazing. She's not nursing anymore. She's retired, but um, yeah, I had just an awesome experience. And then because of the military, I got to actually stay on that same ward for a while, because we do sort of after you graduate, they want you to go back, stay in the hospital for a while just to kind of hone those clinical skills. So I got to stay on that same ward for a while. And then I went to a thoracic surgery and respiratory medicine floor for a little bit. And it wasn't until kind of the following year that I got down into the emergency room.
Mhm.
And I was really grateful for all the other skills I had. I think it prepared me well for emerge. I've seen some people come for practicums in my emerge, and I've seen some nurses, they've done okay. But I've seen a couple that either haven't been successful or they've really struggled because there's such a fast-paced, high-demand environment. You really need to kind of hone some of those that nurse's intuition. Looking at a patient and it, sitting there at the triage desk and somebody walks in and I'm like, I don't even know what your complaint is, but I know that I need you in the chair in front of me right now because you
Mhm.
don't look right. Sure
Mhm.
enough, they're having a big STEMI. So definitely that would be my advice for sure.
Yeah, and that would be mine as well. When students ask me that, I always tell them, like, I wouldn't recommend that as a first step, only because when you're a new nurse, as they say, it takes about 2 years before you're comfortable in your role as a nurse. And in those 2 years, you're really building confidence in skills, confidence in assessments, confidence in documentation. And that's not the place to be doing it in emerge because you're going to miss some things.
Definitely.
I do think that there's a lot of value in being on the floor and putting those pieces together. And you'd mentioned some things I hadn't considered, like where the residents fit in and all those other allied health team members and how do you consult somebody. Trying to figure that out in an emerge situation is not ideal.
what's an occupational therapist and what the heck do they do in the hospital? You know, that kind of thing, right? Like,
Yeah.
I mean, I think a lot of nurses probably, um, I use OT as an example because they are so valuable.
Mhm.
Social workers and some of the programs are able to access for our patients and things that you never even thought about. And the ward really, I think, put me in a great place to learn about all of those things.
Well, even just the interpreter services you have available. Like
Yeah,
when you're in a merge
absolutely.
and you're in a crisis, you don't have time to be calling around and say, how do we deal with this? You kind of need to have some of those answers already.
For sure.
Yeah. So how long did you stay in emerge?
Well, I have been on and off at emergency at HSC now for 10 years. So I still work there.
Yeah.
Yeah, I love it. I'm going to be working there now more again with my new position since leaving the regular force of the military very recently. I've got quite a few shifts coming up lined up, and I'm super excited because there's some key team members there that have been there for that 10 years. You know, that since I've been there, and some of us even started as like junior nurses together and are now sort of the senior nurses on the floor. So
So when you say key team members, are these team members for your new position in the transport?
So both actually. There's a couple. There's one nurse in particular that I'm thinking of. Shout out to Karen if you're listening. We basically started and emerged right around the same time, definitely within the same 6 months or so, and now we're both working at Stars as well. So
Oh,
she was actually one of my references to get hired there. So she's awesome. She's an unbelievably smart and talented nurse for sure.
that's amazing. Well, you come with an awful lot of experience as well. So let's try to tap into some of that because you went from emerge, you had ICU, you've been overseas on deployments, you've done some training with air evacuation. So how does that all lead you where you are today is what I want to dive into.
Sure. Well, I guess I'll just kind of follow the timeline a little bit. I guess after finishing my chunk of hospital time with the military, um, I went back to the clinic and I was working more of an administrative role. And I hadn't been there for very long when I had asked my boss if I could go on the flight nursing course with the military. And put my name in thinking there was no chance I'd ever get a seat on it. And sure enough, I got loaded onto this course, this junior lieutenant, and it's usually like pretty competitive to get a seat on it. Um, and when I was a few days into the course, I had my interview with the career manager, which for those who aren't familiar with the military, it's kind of the person for the regular force military that determines what job you're going to do, where you're going to live, if you're going to be posted, if you're going to move from say Winnipeg to Edmonton, like Tammy did, or um, and so I had a phone interview with her and she said, yeah, we loaded you on this flight nursing course for a reason is we're actually going to post you to a different position in Winnipeg and we're going to post you to the Air Force headquarters as the air vac coordinating officer, which is a fairly senior program position.
Yes.
And essentially that person's role is to be a little bit of a clinical case coordinator. So basically coordinating all the fixed wing medevac, and the role includes some more rotary now, but at the time it didn't as much. But all the fixed wing medevac within the world, for Canadian Armed Forces operations, you're dealing with the special forces, you're dealing with stuff going on up north, like up in Alert, and down in the U.S. and Mexico, and it was really an interesting position. So many dynamic things. Like I mentioned Mexico there. I really had to use my critical thinking skills. I remember trying to coordinate a medevac of somebody out of Mexico that was having a big STEMI, and the cath lab at the trauma hospital had a problem with the equipment and they couldn't actually take him in for angio. And I'm trying to communicate with this Spanish speaking nurse over the phone. I finally had to run over to the Americans that are posted that are in the same building and find a guy whose name sounded, pretty convincing that he likely spoke Spanish. And sure enough, he did. So he came to my office and was like a translator for me and sort of helped coordinate all of that. So it was a really great job. I had a phenomenal boss, absolutely phenomenal. My boss was amazing. My boss's boss was amazing. The couple of physician team that I work with, they were all so great.
Mhm.
So it really kind of set me up in a really great place. And then through being in that job, I ended up getting the opportunity to take a deployment to Germany to Landstuhl. So that was the big hospital, U.S. hospital, where all the patients coming out of the operation zones in Iraq and Afghanistan were both, the patients would go there, where they would spend time in the ICU, sometimes go for further surgeries, and then we would prepare them to be brought back to Canada or the US.
Mhm.
In my case, from when I was there, mostly the US at that time. Canada was just closing out its mission. I was actually the last permanent Canadian liaison nurse there. So that was a really incredible opportunity. Definitely I mean, every nurse joins the military for the deployments for the most part. And that definitely was the highlight of my career on the military side for sure.
That's the one thing I say I miss all the time. Like when there's stuff going on in the world and I know people are going, I'm like, I want to be there. I think that's just that emerge ICU nurse mentality is you want to be in the fire, you want to go, you want to participate, you want to help out. Not that they
Want to
don't.
be part of the team too. Even now seeing our colleagues who are going into the personal care homes in Ontario and Quebec, to support some of these places that are overrun with COVID-19, that they're still so much on the front lines, and they're the pointy end going in for battle at this particular time. And it happens that we have a slightly different form of enemy right now, but definitely it's a huge part of it for sure.
Yeah, absolutely. So you'd mentioned this position at the Air Division headquarters. I actually spent a year there as well.
Yeah,
Fabulous, fabulous crew to work with.
definitely.
Really great memories. And the tour to Germany came as a result of that position.
Yeah, I just having been there, there was actually someone else from our aerobac flight in Trenton who was supposed to go, was lined up in the position, and then ended up going for their medical and had a bun in the oven. So they it was not appropriate for deployment at that time. So when I got the heads up, it was like, think about it, go talk to your husband. If you're going to go, we need all this paperwork done tomorrow, because you have to go on training in the States, and we have to get it all sent off, and it's due tomorrow. So we didn't have any kids at the time. It was a pretty easy discussion with my spouse.
Talk to us about some of the training that you would need then for those jobs. So for those who are listening are thinking, okay, AirVac sounds really cool, and it's going to lead into your new position with the STARS and the transport of patients. What was some of the training that you took? Because obviously you can't just step into a job like this.
No, for sure. Definitely a big part of it. At the time, the military's flight nursing course was about 10 weeks long. Aeromedical evacuation, as the military calls it, and it was a combination of nurses and medics working in the fixed wing environment. So transport nursing has, and we'll get more into that probably later in the interview, but there's some really dynamic bits and pieces of transport nursing that are so unique. And one of them is even things like the flight safety element. So learning about the aircraft that you're on, learning, if you're on a big, large fixed wing aircraft, you need to know, where's the fire extinguisher in the event of fire? Where's the additional oxygen masks if something happens? What if my my ambulatory patient goes into the washroom and they pass out? How do I open the door from the outside to make sure that we can get the patient out of the washroom safely? What's the role of the flight steward on the aircraft? What's the role of the loadmaster on the aircraft? So there's a lot of that element. Little things like, how do I take this oxygen tank and this regulator and put them together? And anybody that's a medic that's listening to this right now, or who has a medic background, is probably laughing their butt off to hear that, because nurses are not super strong at that stuff as a general rule, because our oxygen comes out of the wall, usually in a fixed facility. So all of those things, remembering to take your gloves that might have petroleum product of some kind, oil or gas, off before you handle the oxygen tank, all of those little bits and pieces. So
Lots of
that was a 10-week training course, where we learned to fly in a couple of different aircraft. We also had a cargo compartment trainer that was a old Hercules aircraft that was set up in a small hangar, where we spent a lot of time in there loading patients, unloading patients, setting up stretcher stanchions, doing sort of all of those other bits and pieces. So that was definitely a really rewarding course. That one was definitely another big career highlight for me, for sure.
Mhm.
And then, like so many things in the military, it's kind of on the job training. Like, the number of things that the number of roles a military nurse can be in is so vast and diverse. And in fact, most nurses have had a list of many, many different roles on their resume by the time they complete their time with the military, whether they do a full career or they do a shortened career. For me, I did about 12 years. Um, so, it's a kind of a great opportunity to try some different jobs, try some different things. I never did much in primary care or community health, whereas others have really focused on that because that's definitely a specialty in and of itself.
Yep.
Some of our nurses have done things like gone to our permanent clinic in Germany and spent 3 years posted there where they're looking after spouses and children and doing all kinds of really diverse roles for sure.
Yeah, I definitely tried to get that one.
Yeah.
I tried to get the French course too, but I just couldn't get into those
Yeah.
opportunities. All right. So from emerge into, now I know in the military they combine emerge and ICU into critical care, but it sounds like you spent a good amount of time in emerge first, and then you transition to the intensive care afterwards, or?
Yeah, one of a pretty good piece of advice that I got early in my military nursing career is, if you specialize really quickly, you'll back yourself into a corner and you might close some doors. Which for myself ended up being a great piece of advice. I know for other nurses in other circumstances, maybe depending on what's going on in the world at that time, it was maybe great for them to do that right away. But so I spent a few years as kind of a general duty nurse, med surg kind of nurse, doing med surg and emerge. More surgery and emerge. Medicine was always my, like, okay, I'll just get through this, but it's not my jam, but that's okay. I treat lots of medical patients now in my new role. But yeah, and so probably after, let me think, I think I'd been a nurse for about 5 years when I decided it was time for the ICU. I was very fortunate with the military that I had the opportunity to have my ICU education paid for as well. Now I know through most hospitals and regional health authorities, that's an option for a lot of people. There's usually a payback of time involved. So I was very fortunate with that. I actually got to go to Toronto to George Brown College. I spent 4 months in Toronto. I was living right downtown at King and Yonge, and I was 3 blocks north of me was St. Michael's Hospital, where my clinical was, and about 6 blocks south of me was the waterfront campus of George Brown College, where all my classes were and my labs and stuff like that. And so I really got to immerse myself really deeply in it, and that was it was good timing as well, because actually just before I went on the course, I became pregnant with my son too. So I didn't have the distractions of wanting to go out on a Saturday night or anything like that either. And I just mostly wanted to sleep a lot and study and sleep and be in the hospital. And that was about it. And didn't have little kids needing my full attention all the time yet, like my current life.
Like you do now, yeah. Now that's an intense course. So I didn't know they moved to Toronto because I took it in Halifax at the Registered Nurse Professional Development Center, and it was a fabulous course then. So I'm sure it was fabulous in Toronto as well. And then you came back and worked in the ICU for a little bit.
I did, yeah. I went. I was first in St. Boniface Hospital in the med surg ICU there for a little while. Took a little bit of a break when I had my baby. So I had my son, and then I went back to work. I didn't take a full year off for maternity leave. I only took about 8-9 months. And then I went back and I was in the surgical ICU at Health Sciences Center, which was a great place to be because that's where it's a big trauma neuro center. So you get really all the sickest of the sick traumas and all your neuro patients, people who had brain bleeds and brain surgeries and, sustain these massive car accidents and, other traumas. And so it was definitely an awesome ward. And I really enjoyed my time there. There's such a wonderful team for sure. I worked with kind of a senior nurse there as kind of my nurse mentor, and he's been nursing forever and is the best, hands down, the best ICU nurse in the world. If I'm ever in the ICU, God forbid, I want him to be my nurse. He's just absolutely incredible. So I learned a lot of really great skills from that team.
Now I can't remember. Do they have a medical ICU as well and a surgical ICU?
There is, yeah. There's a large medical ICU as well.
I know I spent time in both. I actually miss the Health Science Center. It's a fabulous. I mean, I think I was spoiled that being my first placement as an ICU nurse. I then worked at the Grace Hospital, which was lovely as well, much smaller. But coming out to Edmonton, I worked in the ICUs here. Nothing against them. They just don't have that same bright, open. Yeah, it's just a different feel.
Hmm.
I
For
got
sure.
spoiled there. And the healthcare aides were so fabulous. They would come around and turn my patients every 2 hours. They would just come around like
Oh, fabulous. Yeah.
the
Yeah.
entire floor. And I'm like, that didn't exist here. I'm like, whoa, wait.
Yeah. Yeah, they're such a amazing team there for sure. And we're lucky the two ICUs or three ICUs, because there's the IICU as well. But they're all in the new building at the hospital. So technology there is much better. There's more than like two plugs in a room where you're trying to look after an ICU patient. So
And so then you've got this ICU specialty. Did that come after the air evac?
it did, yeah.
Okay.
So I started Aerovac as a general duty nurse, so more um, preparing to move non-critically ill patients, so patients that would be like not on a ventilator, not on vasopressor medications, or if I was doing that, we would have an ICU nurse augmenting our team. So if I was part of the transport, there would be an ICU nurse there who was kind of a specialist, like we call them a mission specialist. And
Mhm.
their job would be to really focus on those things. And then my job would be sort of all the other logistical bits and pieces of the mission, making sure that we're safely loading the patient onto the aircraft, getting them properly secured on the bed, kind of all of those other bits and pieces that are all really, as I said, unique to the transport environment. Remembering that the patient that is sedated still needs ear protection, for example, like sort of those little things that you often wouldn't think of, especially if you're in a louder aircraft. Definitely a factor in a rotary environment for sure.
Mhm. And there's so much to prepare. People just think that the patient gets loaded onto the helicopter or the plane and off they go, but there's so much prep that goes into getting them plane ready or air ready, that I was always amazed. I recall in the ICU, the one thing that stood out to me was having to switch out the air for water in the intubation tube.
Yeah, we don't do as much of that anymore as kind of a practice that's gone by the wayside, just because there's
Mhm.
been some great studies that have been done as to like how much change in cuff pressure do you really get. So the newer practice now is to check your cuff pressure at altitude and
Oh,
then adjust your cuff pressure accordingly. Which makes sense. The same with art lines. You just level and zero your art line before you go. You level and zero your art line again when you're at altitude. You know what I mean? But for a long time, it was quite common to use water in the ET tube cuff, the trach cuff, um, sort of as you would with a Foley balloon.
yeah. Yeah. Interesting. And interesting to hear that it's advancing and changing as well.
Totally. Well, and that's one of the greatest things about nursing is we don't just do things because the person who's been doing this for 30 years tells us to do it, but we're a highly educated career, just like anyone else.
Mhm.
I'm finishing up a master's program right now, and I'm in the same program as plenty of physicians. We all have a practice that's driven by medical evidence and strong study design and things like that. So,
Mhm.
I think that's hugely important.
Yeah. So we talked about the air evac course being one thing that you need for your new role here in the STARS air
Mhm.
ambulance. Is there any other training
So,
that you need to have?
well, as far as stars themselves, so I guess maybe I could talk a little bit about that. So, my main role now, outside of the military. So in the beginning of March, I actually left the full-time military, released after 12 years, transferred to the reserve force, because I had accepted a new position that I started training for back in December. And so STARS stands for the Shock Trauma Air Rescue Society, which is the main rotary medevac provider for the three prairie provinces, so Alberta, Saskatchewan, and Manitoba. They have a total of 6 bases, 3 in Alberta, 2 in Saskatchewan, 1 in Manitoba. And essentially they provide rotary critical care services. Most of our patients have sustained either major traumas. Um, we do kind of 2 types of calls. One's called a scene call and one's called an IFT, or an interfacility transfer. A scene call is usually major traumas like car accidents is a big one. A 900-pound hay bale lands on you when you're farming. I went to that one a couple weeks ago. Um, those types of things, we're really with patients when they're kind of on their worst day for sure. ATVs and snowmobiles are a big source of our business too. And then interfacility transfers for people who show up at a rural hospital and they're very, very sick and they are too sick to
Road.
hop in an ambulance and take a 2-hour ride from, say, Brandon, as an example, to Winnipeg. They need to be intubated in Brandon. They're on vasopressor medications. Maybe they're still unstable. Maybe they need surgery that can only be offered in Winnipeg, something like neurosurgery, for example. So we respond, in the fastest time, obviously using a BK-117 helicopter, which is the helicopter we fly currently in Winnipeg. So yeah, that's kind of my new job. The training for that is several months long. STARS run something called the STARS Academy, which is actually available to people who are either a new hire at STARS or can actually be taken by somebody that doesn't actually work for STARS. You can pay tuition to come and attend the STARS Academy. We had a couple of people there who worked fixed wing in other provinces, a couple people who worked in smaller communities, whether they were paramedics or nurses, people who were maybe interested in becoming an employee of STARS down the road, because it's definitely an asset to have already taken that program. When you go through the hiring process, obviously, if you're known to the organization, it might increase your likelihood of securing a position with them. So it's really a great program. Obviously, the outcomes and testing goals and things are a little bit different for the internal people who are really, we need to be, right up to snuff on our specific policies and procedures for our organization. But lots of sim learning, weeks and weeks and weeks of online learning, online modules and forum discussions, and looking at the latest research, and it's a really good program for sure. So for me, it ran from the beginning of December until just recently.
Well, it's intense.
Yeah, for sure.
And before you even did that, did you have to have your ACLS and those kind of things? Were there any training you had to have checked off before you could even apply for this?
Yeah, so they the main courses they're looking for are ACLS and ITLS is actually preferred to the TNCC course. It used to be TNCC, but ITLS really is more of a paramedic focused course, but certainly nurses are welcome to take it as well. And it just gives you a little bit more background as far as scene size up. And what they're actually looking for ideally is people who have not just taken those courses, but have experience working in all of those areas, and ideally would be an instructor in one or both of those courses. I personally am an instructor for ACLS and TNCC. And they definitely like nurses that have had a background in both the emerge and the ICU, because the transport nursing, what I do is neither. It's neither, and it's both. I have ICU skills that I use, I have emerge nursing skills that I use, and then transport nursing skills that I use, and those are things that I wouldn't do in either the emerge or the ICU. So they like you to kind of have a background in both. So definitely have taken a formal ICU course, or a formal specialty advanced emergency course, which I know are offered in some areas. We don't have a program like that in my health region, but I know in other cities there's definitely advanced emergency nursing programs as well. So those are kind of the main things that they're looking for people who definitely have a desire to participate regularly in nursing education, like sort of always getting better. We do education rounds every month where we do an online learning module every month. We do a skills checklist every month of a skill that we maybe don't do that often, like assisting with the insertion of transvenous pacing, for example, and then actually managing the sort of the electronic device that controls the transvenous pacing. So it's constant learning all the time. It's going to be constant learning until the day after I retire.
And even beyond, hopefully.
And even beyond, totally.
So in your role, do you have a physician that comes with you, or are you the game? Like, are you the lead?
So yeah, the team, the main team essentially is a registered nurse and an advanced care paramedic. That's our basic team. And then we can be augmented for certain calls with a physician. So just going back to the same example that I used, if we had a patient where we knew we were going there to insert a transcutaneous pacer, our physician would either come down to the base, or we would fly to the hospital quickly and pick them up if that's where it's easier. Maybe they live close to the hospital. And we would bring them with us as a third. That transport physician is always part of all of our calls from an online medical control perspective. So they hear about it from dispatch, they hear, or from our link center in the other provinces. The logistics of how we're dispatched is a little different in Manitoba, but they're involved in the discussion. If it's an interfacility transfer where we've been requested, we'll get on the phone and we have ourselves are there, our docs on the line, the physician or nurse that's requested the transport with the patient is on the line, the dispatch center is on the line. We have a quick discussion, get a bit of a report, figure out what's required. So they're definitely there for us all the time. They're only a text away or a satellite patch away, or they're definitely there with us in spirit, but often not all the time physically, for sure.
Yeah. Now I know you've only just begun this job just recently. So talk to us about the first call you had, your thoughts, your feelings, your concerns, your excitement. I mean, there must have been a lot going on in that moment.
Yeah, for sure. So the first call I went to was an interfacility transfer for a lady that had essentially had been sort of found unconscious. So she was a little bit of a mystery to from a medical perspective. So it was just before COVID, not just before, but it was before COVID-19 started ramping up, and thank goodness, because otherwise we would have been PPE'd from top to bottom. In her particular case, we actually couldn't rule out something like meningitis, so we were actually wearing N95 masks as well, just in case, because she did have a bit of a fever when the paramedics first attended to her. There's things in the transport environment that really add to your cognitive load. We use the term cognitive load a lot. Mm-hmm. In the hospital, you're not dealing with things like, man, my helmet is sure tight today, or I didn't do my chin strap up just right and it's digging in a certain way, but I've got PPE on and so I don't want to touch it because it's in my face, or I can't reach that, or I have this in my vest, but my vest is under a gown, is some of the challenges we're dealing with right now.
Yeah.
So there's definitely just some added bits and pieces. And probably one of the biggest ones is just the independent decision making, for sure. Now, obviously most if not all of the decisions are always made in collaboration as a team. For me to do particularly a large intervention without checking with my partner and discussing, I think just based on that blood pressure, I think we're going to start a norepi infusion at 0.1 mics per kilo per minute. I'm going to mix up a norepi now. We're always chatting with one another as to what we're going to do. We do have a really well laid out set of clinical protocols that we use to help guide our care, obviously, and then always have our physician, as I said, available to us as well. So,
yeah. There was a time I was on the airplane and, so I wasn't even in a role, but I always thought I would be good in these stressful situations, which is why I wanted to know about your first day or your first case, because there was a little ding ding, any medical people on board? And I looked around, nobody's putting their hand up. And so I put my hand up and there's this fellow having potentially cardiac event, maybe gallbladder event. We can't really quite rule out anything because he had some symptoms, not all symptoms. And, of course I'm like, well, what am I going to do for you? I don't have oxygen. I don't have this. I don't have this. Yeah. So they do have oxygen
right now. Yeah.
Yeah, they do have oxygen, but his wife was a retired nurse and she was just wanting second eyes on him. And I remember for the rest of that flight, that was Edmonton to Toronto, I just stared at the back of his head and made sure it stayed upright. And I did not enjoy that flight at all because I was worried he was going to have a heart attack. And I was starting to think about all those cognitive load things, like the seats are not lined up. So you can't just lay him in the aisle and have two people on either side do compressions because the seats are not lined up. And I was starting to think about all these logistical pieces. How will I get him out of his seat? Where will I take him to? What will I do?
Well, you heard it here first. NurseMinder Podcast. If you are ever on an airplane, you're not sure if someone's having a heart attack, you can't go wrong by giving them 160 to 325 milligrams of ASA. They probably have it and have them chew it. They probably have it on the aircraft. And if not, somebody on the aircraft probably has it in their purse.
Yeah.
And that's your best bet. And yes, maybe some oxygen, and definitely come up with a CPR plan. And as you did. And that's really about it. I think some of the bigger international flights carry more of a medical kit where there's a few more things. I received a patient in Emerge one time that had actually been intubated on board a flight from France en route to San Francisco, I think, or
Wow.
LA or something. And she'd been intubated somewhere over Greenland, actually. And then they landed in Winnipeg because that was the next major hospital on their flight path. So
That's
they did have
crazy.
intubation supplies on that big aircraft, and they obviously had a doc that was
Yes.
capable of doing it.
Yes. Well, I learned on the second flight that day because there was a seizure on the second plane.
Oh gosh, two
I
in one
know.
day.
2 in
Ugh.
one day. I was starting to have heart palpitations.
Did you ask for like an airline credit or anything? You know, guys, like you're
I'm sure
pretty
they
much your employee now.
I'm sure they did something. I don't recall what it was, but we were traveling was military for volleyball. The whole team,
Oh yeah, yeah.
right? So on the second flight, thankfully there was a medic, and he grabbed that guy out and hauled him to the back. And of course, I want to start an IV and I want to do all these things. And they got the doc on the phone. He's like, "You can't start an IV." I'm like, "But there's stuff here. I can do that." He goes, "You have nothing to give him. There's no reason to start an IV. You don't have any phenytoin. You don't have anything to treat a seizure." I'm like, damn, I don't know what to do in these cases. I want my team.
Yeah. And even little things, right? Like the angle of starting an IV. One of the things in the aircraft for me, if I need to start one while in flight, is just kind of getting myself in the right position. And the other thing is remembering that if I'm starting an IV or sometimes an IO, which we might start at a scene call, always remembering that the best position for the IO for me is the left humeral head, because that's what's facing me, that's what's closest to me, and that right arm is really tucked far, far away. So kind of avoiding having anything on there, you know, whenever we can too. And those are just little things where you kind of have to do it the first time. Another one with the IO, you know, for any nurses that have worked with IOs, that's an interosseous line. That's the one that we put in with kind of the drill in an emergency situation. If you've ever worked with the Easy IO, you got to put the stabilizer device on before you attach the extension set, because if you don't do that, you're not going to be able to get the stabilizer device on there. And I know anyone who's worked with them before is giggling right now because they've probably all done it. And I did it on a call not that long ago, myself and my partner, and we both said a couple of four-letter words after we did it.
Yeah. Those are the things. You're right. You have to just do things the first time to realize, okay, no, I want it in the left. What was it? The humerus?
Left humeral head. Yeah.
Humeral head. Yes. See, you'll always do it that way now. You just go straight there.
Totally. Yeah.
Oh, that's pretty amazing. Well, those are some pretty interesting stories. I don't even know where we're all going to go today because there was so much to cover there. And I see it is, I don't know, how long have we been online? I'm not even sure. Is there anything that I haven't asked? Yeah, I know. It goes fast, right? Is there anything I haven't asked that you wanted to share with the listeners?
You know, I don't think so. I think for me, I'm, you know, I still like to think after 10 years, I'm so early in my career. There's so much more to be had. And I guess the biggest thing is just encouraging nurses just to never stop learning, like not give up that, you know, going to nursing school and graduating nursing school. And I hope that this doesn't give anyone any anxiety to hear, but the day you graduate from nursing school, you essentially know nothing.
Mm-hmm.
And you're so green and you're just brand new, and open your mind. Maybe you were shown how to do it the one way in the skills lab, and maybe you had a bit of an instructor in the skills lab who felt that that was the only way that this dressing, you know, that you should do your sterile technique or set up your field, or this is the only way to prime your IV line, or little things like that. But there's lots of different ways you're going to learn from everybody along the way that you encounter, whether they be a formal instructor, whether they be somebody at the bedside, whether it be a nurse who maybe you observe a behavior or a certain clinical practice that you don't agree with, or that perhaps is less than ideal. Because let's be realistic. I mean, we're not all angels, and I certainly aren't one either. I've definitely picked up bad habits along the way, maybe even not necessarily realizing it. So just sort of never give up your desire for learning. Take any course you have the opportunity to take, any conference you have the opportunity to take, any opportunity to be a member of a professional organization such as NENA, the National Emergency Nurses Association. We were, this is my little shameless plug, we were supposed to have Empowered 2020 conference going on basically this upcoming weekend, actually. I think pre-conference, the first day of the pre-conference was supposed to be today, but of course, because of COVID-19, we won't be doing that. So Winnipeg next year in April of 2021, we'll be having a NINA conference. So for sure, anybody who's interested in emerge nursing or is just starting out in emerge nursing, there's always a student rate as well. Students are encouraged to come too. Definitely check those conferences out, because the education you get there, plus the people that you network with and people that you might meet along the way, can really help you out in your career for sure.
Absolutely. Absolutely. That's a good point. Awesome. Well, thank you so much for joining us today. It's been lovely kind of getting a little snippet of each of those areas, you know, the trauma unit, starting out there right after school, getting your kind of feet there, the emerge, the ICU, the transport. Over to Germany, we traveled for a little bit. We came back to STARS. You have had a full career already in 10 years.
Yeah, we'll see. Well, I don't know. I've always kind of joked like maybe one day I'll need something to do when, you know, my body can't fly around in a helicopter anymore or something like that. Maybe I'll just go work in like L&D or like the NICU, or just try something, you know, completely new. I don't know.
You know, when I told my husband I was interviewing you, he's like, and I mentioned that you were with STARS, because when I was in the military doing critical care, he was always telling me, you should go do the air evac. I don't know, he must think that's sexy. Like, I don't know what it was about him and air evac. And just the other day when I told him, he's like, you should do air evac. Like, that's not where my heart is. My heart is teaching. Like, I'm not going to do air evac.
Yeah, I like teaching for sure too, but you know, one of my next things that I need to do for sure is I'd love to go do a clinical group at the university, you know, where you did like as a clinical education facilitator, or you have your group of 6 or 8 students and you get to go do bedside teaching in the hospital, and a couple days a week. That's like for sure on my professional bucket list of something I want to try a couple of times for sure.
Yeah, that's pretty awesome. No, I knew once I had those 2 calls in the same day on the plane, you know, of course I equate that to air evac. I'm like, nope, I want my team. I need my room. I need to know everyone's role.
And that's totally okay. I mean, I've brought in, I was on a pretty awful call with a poor outcome a few weeks ago. And, you know, we brought a patient into just a room of everybody, like everyone was there, you know, and we had been 3 people out in the bush in an area that was so remote, no medics or no like ground medics, no fire, no nothing like that. Hey, and just arriving to this huge team. And afterwards, one of the docs that was working in emerge that day, but also happens to be one of our transport physicians with STARS, he'd said, like, you guys did such a great job considering the resources you had, like your 3 sets of hands and 1 very, very sick, critically injured, life-threatening injury, you know, you do what you can, right? And we were dealing with the cold and snow and safety concerns with landing the helicopter and trying to make sure that we didn't become 5 patients or 6 patients because of the patient plus our crew of 5, you know, because we had to make sure we could land safely and didn't hit a tree with a tail rotor or anything like that, you know. And so those other extra elements of transport nursing for sure, you know, poor lighting, sometimes you're too hot, sometimes you're too cold, you know, vibrations, sometimes your helmet's little pressure spot the wrong way for the 2-hour flight back, and there isn't really much you can do about it, you know. But definitely for anybody who's interested in getting into those fields, as I said, it's definitely not, transport nursing is probably not for the brand new nurse. You have to make a lot of decisions, and you have to have strong clinical assessment skills. You have to be ready to recognize when the situation is going poorly, and you need to reach out to your physician, or you need to ask to have somebody else on the transport with you if you're consulting and haven't gone out yet, whether you're in fixed wing or rotary. You need to recognize your own limitations too, but definitely starting out in a high acuity emerge, get some ICU background, lots of learning, ask lots of questions, and you can definitely get there.
Yeah. It actually made me think of another question. It made me think, so you're talking about that last call, and I'm thinking about the environments that you guys are flying into. They're not highways where you can land. It's not always safe. And then I was thinking about search and rescue. Do you often work in tandem with search and rescue, like for those like mountainous kind of recoveries, or is it you would go to that same mountainous range if there was a patient?
Yeah, really, our environment is so ever changing. So we definitely work with the STARS organization. We call them our allies. Our team of allies is so huge. So definitely, search and rescue with the RCAF is a part of our partners. I know we did have a mission that was done. I think it was a couple years ago now in the summer, where somebody had been out on a trail in the Whiteshell and been fairly badly injured, and the weather was not didn't facilitate getting the helicopter in. I believe that was the scenario. So actually, the SARTEX actually jumped out of a Hercules aircraft that was able to get in, jumped in, stayed with him, stabilized him, and actually helped keep him warm and stayed with him all night long, fed him, got him hydrated, did all those things, essentially kept him alive until the next morning when a STARS helicopter could get some access in order to get him out of there. So definitely they're one of the many allies we work with for sure.
Yeah. And you guys must be humping a lot of gear as you're heading over to those scenes, I would imagine.
Yeah, the one I described in a more remote area, we have some extra equipment that we can add to the helicopter if we know that we're going to a really remote location, including a big backpack that holds an oxygen tank and a bunch of other things. For sure, definitely a job where we have a gym at the hangar and we need to go to it and make sure that we keep ourselves fit and healthy. That's a big part of the job too. And then that also plays into your mental health as well, because we work in a high acuity, high stress environment. We have a great CISM program, and we're so close. I mean, we're only 8 nurses and 8 medics at my base, plus our team of pilots. And we're so tight with one another, so we know, everybody knows when someone's been on a particular call. After that tough call, I got a couple of texts over the next couple of days just being like, hey buddy, just checking in, if you ever want to talk about it, or
Yeah.
which is awesome. And I'm starting to see that happen more in my emerge now too, after really tough days. You know, you have a couple of nights where you have multiple gunshot wound victims that have been brought in, that have been incredibly sick and all had resuscitations, and none of them have survived, or maybe only one of them has survived. It's really important to have your network of people for sure, and to know that you can just talk about it over a glass of wine or a coffee or whatever, and that's healthy. Like it is okay to have kind of that normal reaction to an abnormal experience for sure, because definitely in critical care we see a lot of things that you wouldn't necessarily see in other areas of nursing that can be
Yeah.
a little harder on you.
Yeah, no, absolutely. Absolutely. Well, thanks for sharing that and giving us such a good insight into the daily life of Kelsey Penner.
Yeah, no worries.
I'd like to thank Kelsey for spending so much time with us today and really opening up about the various roles. Now, if you have a story you'd like to share, email me at info@tammydunnett.com and use the subject line Frontline Nursing. If you're looking for more information, you want to hear about the conversation we had about our kinesiology training, head on over to frontlinenursingpodcast.com, join up in the members area, and get the after the recording session and the video footage.